Hello and welcome. Today's presentation is on the hemodynamics effect in prone positioning. As we all know, prone positioning is something which we do in ARDS patients. In this video, we will dive deep and try to find out what are the hemodynamic effects that we see in prone positioning. So the first question, is prone positioning recommended for patients with moderate to severe ARDS? Yes, it is recommended if the PF ratio is less than 150 millimeters of mercury, despite optimization in the mechanical ventilation or the use of neuromuscular blockade. Now, what is exactly optimized mechanical ventilation is not yet defined. It is something which you do at the bedside. If according to you, your mechanical ventilation is optimized and you have used neuromuscular blockade and you still don't find any improvement, then you can prone the patient. The next question, how does prone positioning improve arterial oxygenation? It mainly does it by improving the ventilation to perfusion ratio, which is by increasing the aeration and ventilation in the most dorsal parts of the lungs and maintaining the pulmonary blood flow into these parts, thereby improving the ventilation perfusion ratio. Now, how is the use of prone positioning changed in the recent years? Now, in 2014, only 16% of the patients with severe ARDS underwent proning. However, with the recent COVID-19 pandemic, more than two-thirds of the patients with moderate to severe ARDS had several sessions of proning done. Now, how does prone positioning affect the venous return and the right ventricular preload? Prone positioning affects the venous return by increasing the intra-abdominal pressure, leading to an increase in the mean systemic pressure, and subsequently the central venous pressure also increases. This results in an increased pressure gradient of venous return, and if not countered by increased resistance, an increase in the venous return is seen in these patients. This leads to an increase in the right ventricular preload. Now, what are the two main effects of prone positioning on venous return? The two main effects are, first is by increasing the mean systemic filling pressure and the CVP, it results in an increase in the pressure gradient, which increases the venous return. However, if there is a substantial increase in the resistance to the venous return because of the increase in the intra-abdominal pressure, it can result in reduction of the venous return. How does prone positioning increase the mean systemic pressure? So there are two ways by which it is happening. The first is once there is lowering of the trunk from a semi-recumbent position to a strict supine position, it leads to a passive shift of blood from the splanchnic compartment to the heart because of the gravity and the position change. And this increases once you make that supine position into a prone position. Now, how does prone positioning affect pulmonary vascular resistance and the right ventricular afterload in ARDS patients? Prone positioning decreases the pulmonary vascular resistance and the right ventricular afterload by reversing some of the mechanics which are responsible for RV dysfunction, which are, it improves the arterial oxygenation, allows for more homogeneous alveoli aeration, there is decreasing compression of the intraalveolar vessels, there is reduction in the transpulmonary driving pressure, preventing high PEEP level requirements, and increasing venous return and central blood volume. Now, how does prone positioning affect the right ventricular dysfunction in the ARDS patients? Now, as the things that were described before, prone positioning helps improving the right ventricular function by decreasing the hypoxic vasoconstriction, thereby reducing the afterload on the right ventricle, recruiting non-aerated alveoli, increasing the diameter of extra-alveolar vessels. This results in dampening over-distension in the hyperinflated lung areas and decreasing the pulmonary vascular resistance and subsequently the right ventricular afterload. How does prone positioning affect the left ventricular preload? Now, prone position can increase the left ventricular preload in ARDS due to improvement in the right ventricular preload and afterload, as well as an increase in the pulmonary artery occlusion pressure. In patients with RV enlargement, Prior to prone positioning, the reduction in the right ventricular afterload dampens the right ventricle to left ventricle interdependence, leading to an increase in the left ventricular end diastolic volume, thus increasing the LV preload. Does the effect of prone positioning on hemodynamics and right ventricular function contribute to the beneficial effect on the outcome of these patients? Now, it remains to be determined whether this hemodynamic effect or the right ventricular function improvement contributes to the beneficial effect. However, the prone positioning has been shown to be beneficial in the ProSIVA trial, which was defined by changes in the blood gas variables. So we are not sure whether it is the hemodynamics or the change in the blood gas which is improving the outcome. What are the overall effects of prone positioning on cardiac output? The effect of prone positioning on cardiac output vary among studies, with some showing little or no effect, while others reporting an increase in the cardiac output. The changes in the cardiac output with prone positioning likely depends on the volume status and the degree of preload responsiveness before the proning was done. Cardiac output increases only in patients who have a left ventricular preload reserve, but it may decrease in both preload responsive and unresponsive patients if the intra-abdominal pressure increases significantly, resulting in an obstruction during the prone positioning. Now, how can the increase in the intra-abdominal pressure in prone positioning be minimized to reduce its detrimental effects on the circulation in ARDS patients? Now, to minimize this, use an air cushion mattress instead of a conventional foam mattress, which may help as it is associated with more limited increase in IAP. Additionally, avoid using the thoracopelvic supports or limiting their usage with high increase in IAP in prone positioning can help, as their application has shown to worsen hemodynamics without any advantages on the gas exchange. Does the increase in IAP with prone positioning impair the perfusion of intra-abdominal organs in ARDS patients? The increase in IAP with prone positioning is generally limited, and as long as the cardiac output is preserved, studies have shown that the hepatosplanchnic perfusion, liver function, gastric intramucosal energy balance, and the renal function are not impaired in ARDS patients. What is the importance of detecting the preload responsiveness in ARDS patients, and what alternative maneuvers can be used in prone positioning? Detecting preload responsiveness in ARDS patients is important because insufficient cardiac output may worsen the hypoxemia, and only half of the patients would effectively benefit from fluid administration in terms of increasing the cardiac output. Now, the risk of worsening the lung edema and the associated cumulative fluid balance with high mortality highlights the need to carefully evaluate the risk-benefit ratio of fluid therapy. In prone positioning, the Trendelenburg maneuver can be used as an alternative to passive leg raising for assessing preload responsiveness. This maneuver mobilizes blood from the splanchnic venous reservoir and the lower limbs to the intrathoracic compartment, thereby increasing the cardiac preload. How effective is the Trendelenburg maneuver in diagnosing fluid responsiveness in ARDS patients? In a study of 33 ARDS patients in prone position, the Trendelenburg maneuver was found to be effective in diagnosing fluid responsiveness. The AOC, that is the area under the receiver operating curve of the cardiac output, changes during the maneuver was 0.9. Now, the increase in the cardiac output, that is more than 8% during the Trendelenburg maneuver, enabled the diagnosis of fluid responsiveness with a sensitivity of 87% and a specificity of 89%. Now, what methods can be used to detect preload responsiveness in patients with prone position? Several methods can be used. The one that we have already discussed is Trendelenburg maneuver, which increases the cardiac output by mobilizing blood from the lower limb and splanchnic compartments. The other is end expiratory occlusion test. It is a 15-second expiratory hold temporarily, which decreases the intrathoracic pressure, increasing the cardiac preload and output in preload responsive patients. The next is pulse pressure variation. Arterial plus pressure during mechanical ventilation predicts fluid responsiveness and may be affected by low tidal volumes and impaired lung compliance in ARDS patients. Next is tidal volume challenge. A 1-minute increase in tidal volume from 6 to 8 ml per kg of predicted body weight predicts fluid responsiveness. Finally, a mini fluid challenge. Administering a small fluid bolus of 100 to 150 ml in 1 minute and measuring the changes in hemodynamics can predict fluid responsiveness in supine conditions, though it has not yet been evaluated in prone patients. Now, how reliable are these methods in detecting preload responsiveness in prone position? Now, the reliability, as we have already said, in Trendelenburg, the area under the curve is 0.9 with a sensitivity of 87 and specificity of 89. The end expiratory occlusion test has an area under the curve of 0.93 with a lower cutoff percentage for cardiac output increase, that is 3.2% in one study, but it was not predictive in the other study. In the pulse pressure variation with an area under curve of 0.85 plus minus 0.05 had a sensitivity of 74% and a specificity of 79%, but the gray zone, that is between 5% to 8%, included almost 40% of the cases. The tidal volume challenge, it had a good area under the curve of 0.94 with a sensitivity of 98 and specificity of 86, and was good in one study and was found to be reliable in multiple other studies. Mini fluid challenge is not yet evaluated in prone positioning. So to summarize, prone positioning in ARDS patients has a significant implication for the venous return and the right ventricular function. Increased intra-abdominal pressure can raise the upstream pressure for venous return. Now, prone positioning may decrease the right ventricular afterload, benefiting patients who had a prior right ventricular dysfunction. In some cases, prone positioning could reduce the cardiac output and organ perfusion, especially if the volume status is not maintained or the intra-abdominal pressure is high. Now, hemodynamic assessment includes echo and cardiac output monitoring, which is very important in these patients. Finally, you can do some dynamic tests to check for the fluid responsiveness in these patients. Out of this, the really evaluated tests are Trendelenburg maneuver and the tidal volume challenge, which have been found to be very effective in guiding fluid management in these cases. Thanks for watching today's video on prone positioning in ARDS patients and its impact on hemodynamics. We hope you gained valuable insight to help improve patient care. If you found this information useful, please give this video a thumbs up and don't forget to share it with your colleagues. And please do also share your opinion regarding this video. We'll see you the next time. Thank you.